activity. They're doing 3 hours of activity. So we have to look at everything that's going on with those patients. It's more than just what is the blood sugar and how much insulin to give. So we have this great thing on the inpatient side, and I would encourage every one of you to look at it, and if you eventually work here at Christ, to actually use it. It's called the Glucose Management Tool or Report, and it is available on the home page, you know, the index page. Under medications, it says glucose management. And if you click on that, you're going to get this just great picture of everything related to this patient's diabetes. So you get their lab glucose, their point of care, all the insulin that they're on, what they've eaten, and all this opens up to the renal lab and the DKA lab if you need to see that. The A1C will populate there as well. So I told you our inpatient goal is 100 to 180. For surgical patients, some places are using, 140 to 180, but we went to this 100 to 180. That's where we went. And it's really important, like for open heart surgery patients, to have really tight control. That is very important for any surgical patient. When you don't have tight control, you're going to run the risk of that wound getting infected. We actually could cause people to have DKA in the hospital, which could be life-threatening. Hypoglycemia can be life-threatening. So there's lots of reasons we want to keep these blood sugars under control. So we don't use orals. I told you that. The recommendation here at Christ is to use what's called basal bolus insulin. So we want to understand a little bit more about how basal bolus insulin works, because you're taking care of one of these patients that if they're on basal bolus, you need to know how all these insulins they all work together. So the basal part of the insulin is a long-acting insulin. We say it lasts 24 hours, okay? There's 2 of those insulins on the market right now. One is called Lantus, and that's the preferred insulin here at Christ Hospital. Most of your patients will be on Lantus. We also have Levemir available. It's not preferred, but if you came in on Levemir, then we would probably leave you on Levemir, okay? They're both in the long-acting class. I think our endocrinologists feel Lantus might last a little longer. They both say they're 24-hour insulins, but a lot of patients on Levemir do twice-a-day dosing. So even though I'm saying it's a 24-hour insulin, there are people that are on Lantus twice a day, Levemir twice a day. I've had somebody on Lantus 3 times a day. So it depends on their need. These people are usually the resistant to insulin kind of patients. They need higher doses. The insulin pen available right now only goes to 80. So if your patient needs 100 units of Lantus, probably we're going to split that and do 50 and 50, okay, into 2 injections. So Lantus is a drizzle of insulin. It just drizzles. It's in the background. It's in the background. Basal's just kind of in the background. It's just drizzling all the time. And then we use a bolus insulin or a rapid-acting insulin. We use Humalog here as the preferred insulin. But there's also Novolog and Apidra are the other 2 on the market. And it's exactly what it is. It's a bolus of insulin. It's a surge of insulin associated with meals. So this bolus insulin is really the one you're going to be pairing with meals. It really has 2 jobs. It helps cover the carbohydrates that turn into sugar in the meal, and it also helps to bring down the blood sugar. So it's a mealtime insulin. And it also can be used to bring down high blood sugars, okay? So we give it breakfast, lunch, and dinner, associated usually with a blood sugar and some food, okay? And then we might give some at bedtime if somebody's blood sugar's a little bit too high. This insulin, does anybody know how long it lasts? Does anybody know? Lasts 4 hours, about 4 hours. It peaks in about an hour. So you would know if you were the nurse and you gave insulin at 8 that 9-ish or so, that insulin's going to be working hard. Starts to work in 5 to 15 minutes, so you want to have food on board right away. And then this is just what basal insulin looks like on the MAR. I just copied and pasted that in. You can see this is somebody getting 50 units, that example I used. So they're getting it 2 times a day, a total of 100 units in one day. The pens only go to 80. Sometimes if you deposit that full amount in one spot, they may not get all absorption of all of it. So this is going to change, but right now, always on the medication record, you're going to see if it's higher than 10 units of insulin you're giving, you're going to need to verify that with another nurse. And I believe they're putting into Epic a cosigner for the person that verified your dose. We consider it a high alert medication in the hospital, and we send people home with it. But you want to verify that dose with somebody else. The other thing that's going to be on the MAR, the new orders that's coming out in March, it's going to also say, do not hold Lantus. You know, if you're worried about the dose, you're always going to call a physician. If your patient's NPO or they've had lower blood sugars or you feel like something's going on with that diabetes, you would pick up the phone and call a physician to say, do you still want Lantus 50 given, okay? And then the Humalog insulin is that rapid-acting insulin. And this patient, can you see daily with dinner, they're going to get 30 units of insulin to cover their food. So that set dose, that 30 is to cover the food they're eating. And then they also have a separate entry on the MAR that tells them if the blood sugar is too high to give a little extra. So if this patient had a blood sugar of 167, how much insulin do you think you'd give? Can you see the scale? 167 would be how many units? 4. And if they're supposed to get 30, they're going to eat dinner. You're going to give 30 for dinner, 4 for their blood sugar, and you're going to give 34. You're going to give the whole dose at one time. Okay? So you want the blood sugar just before somebody eats. This is 2 entries on the MAR, 1 for food and 1 for blood sugar. Okay? God bless you. If your patient's not eating dinner, they're NPO, then you hold that 30, you would still correct, you would still take care of their blood sugar. Okay? Some of our patients at Christ are doing something a little more complicated. We have 7 endocrinologists and 2 endocrinology nurse practitioners. And so our nurses know how to carb count. Our menus are marked to carb count. So you could see something that looks like this on the MAR. Instead of a set meal dose, you could see that we're going to base the insulin on how many carbohydrates the patient took in. A little safer method, because when people are in the hospital and they're sick, and we order 30 units of insulin for their meal, and they only eat half their meal, but you already gave them 30 units, that patient could run into trouble. So this way what you would do is you'd wait till after that patient ate, you'd go in and see how many carbohydrates they ate, and then have the associated amount. If they ate 4 carbs, they get 4 units. And then you would also come over and correct their blood sugar. You would use that correction scale. So 2 entries on the MAR again. So let's just say this patient, you counted up their carbs, and they had 5 carbs. How much insulin would you give for 5 carbs? 5 units. And then this patient's blood sugar was 267. How much insulin would you give? So it would be a total of 7. Yeah. Okay. The menus are marked to read the carbs pretty clearly. They're in parentheses behind. Most people are waiting to give this until after the patient ate. I would tell you that if you have a patient and they historically have eaten 100% of their meal every time, you're safe to go ahead and give this right at the time the patient's eating. But if you know this is that frail little 80-year-old and they just have been picking at their food and you don't know if they're going to eat 1 carb or 4 carbs, that you can wait to see what they actually eat. You will be safer dosing that patient.
Would you still give the blood sugar one?
Yes.
Okay.
Yes.
Just hold the carb one.
You could hold the carb. Some nurses do. Some nurses will hold the carb and give the blood sugar. Some will just hold them both and give them both after the meal. Okay. I will tell you that we are actually timing how quickly insulin is given off of this. So you do not want to be 2 hours into it and give a insulin on a 2-hour-old blood sugar. However, you can't test after they've eaten. So I would recommend always getting a blood sugar when you see the tray. That way, if the patient takes 40 minutes to eat, you're going to be within the window of time you need to be. Okay? Does that make sense? When I first started at Christ, getting point-of-care blood sugars was kind of a task where the PCA would just pick up her box and she'd go from room to room, starting at 11. Didn't make any difference when those patients were going to eat. So we've really tried to change that so that we really pair blood glucose testing with your meal. It's what Beth and I teach patients. It's test your blood sugar, take your insulin, and eat. You don't test your blood sugar and then go do something for a couple hours, then take your insulin and go do something else for a couple hours. You do it all together, okay? So IV insulin, it's the most effective way of covering blood sugars, but we can't do IV insulin on a medical floor. It's very time-intensive, labor-intensive. These people have to be checked on constantly, monitored blood sugars. So you're only going to see this in the critical areas, surgery, ER, ICU areas. You're not going to see it unless you're working in any of those areas, okay? Insulin pumps, you will see, there are some days we had 5 pumps in the house. Today we have 2. We have 2 today. So you're gonna, if you're working at Christ Hospital, you're gonna see insulin pumps. Those 7 endocrinologists that are working on the outpatient side, our pump nurses are starting pumps every day on patients. So those people can get sick that have an insulin pump. Our goal here at Christ is to leave them on their pump, provided they're safe to use their insulin pump. Nurses a lot of times are very scared. I think people are getting much better about it, but the insulin pump, it's just an external pump that they wear, and it delivers the insulin through the pump. It's delivering insulin all the time. They use rapid-acting insulin in it, and it's drizzling all the time, like background Lantus, and then they bolus by using the pump. It's like a little mini computer. They dial in what their blood sugar is, how many carbs they had, and they use grams and not choices. The pump calculates the amount, and it can calculate very tight. It can say you needed 12.3 units of insulin. We can't find 12.3 on a syringe or in a pen. So it calculates very nicely so these people can get a little better control. They have this infusion set. The insulin's going through here. People change that every 3 days. And so there are different kind of pumps available. The most typical pump we see is the Medtronic, which was the first one. This is another brand. But it's just a continuous flow of insulin, regulating these people's blood sugars. And again, they're going to control their blood sugar by entering carbs and their blood sugar. And they've got targets built into the computer and how much insulin they need per carb. So it's a pretty nice way of controlling blood sugars. A lot of type 1s will have these pumps. So our hospital policy says it has to be ordered by a physician, and that physician here at Christ is an endocrinologist or a fetal maternal physician. So they have to have a referral to them. So that's a little bit more reassuring to the nurses that we've got specialists on board. Beth and I get automatically consulted with every single pump patient. So these people are pretty savvy about their diabetes. They've had lots of education. To get a pump, you have to have lots of education. So many times we're not doing tons of education with those patients. We are really supporting the staff so that they understand how to manage this pump. People are asked to use our meter. They can't use their own meter. Some of the meters actually beam the blood sugar right over to their pump. They have to use our meter to treat. If they become confused, either a loved one can take care of the pump or the pump has to come off. They have to have their own supplies. We will supply the insulin. So a nurse is going to be responsible for knowing the type of insulin, asking the patient the type of pump on admission, and then inspecting the site, and if the patient's cognitive ability changes, that they would notify the physician. So on the MAR, you'll have 2 line items. One is going to be that continuous background insulin that's drizzling, and it'll just say something like 1.5 units per hour, and it might change. It might say at 3 a.m. it's 1.5, 6 a.m. 1.2, and you just go in and say to the patient, is your pump still going at whatever it's supposed to be going at that hour? And they say yes, you document that. It's all self-administered as the MAR action. And then on the mealtime insulin, you simply ask the patient, you tell them their blood sugar, and then you say how much insulin is the pump telling you to give. You enter that into the MAR. Okay. Again, self-administered is the key to use, the MAR action to use. But it can be scary for people. I had a student with me last year, and he was doing the RN to BSN, and he followed me for a semester. And when we were doing pump things, he's like, when we left a room, he said, it's like they've got a loaded gun. They can just keep adding more insulin. And that's why you want somebody who cognitively is intact. The pump has some safety features in it, but you don't want somebody who can't remember if they bolused or not to have that pump in their hand. So they sign a contract with us. So any patient with a pump should never get sub-Q insulin. They already have insulin on board. You're going to cause lots of trouble. That's why we want to mark these people pretty clearly that they have a pump. You're never going to remove the pump if a patient has hypoglycemia. You're going to treat the hypoglycemia and call endocrinology. The pump does have to be removed, and the infusion site's there, and it just clips in and out. It has to be removed if they're going to x-ray or any kind of procedure, because it's a computer, you can ruin it. And this is all of these things are in the nursing communication if you have a pump patient, and there's a lot. Has anybody ever had a pump patient? Yeah. Do you see all the communications that are out there? Tons.